So good morning, everyone. Welcome to our Regional Geriatric Rounds webinar. My name is Maris Pryor, and I'm the Program Manager with the Geriatric Regional Program of Eastern Ontario. I'll be the moderator for today's session. So before we begin, we'd like to take a moment to share a territorial land acknowledgement for Ottawa, where we are hosting today's session. The RGPO offices are hosted at the Ottawa Hospital, are located on the traditional unceded territory of the Algonquin Anishinaabe Nation. The Algonquin people have lived here since time immemorial. We are grateful to have the opportunity to be present in this territory. Today, Jennifer Koop will be presenting on delirium quality standards in acute care. Jennifer is an advanced practice nurse working at the Ottawa Hospital in the Division of Geriatric. She began her specialization in geriatrics as a geriatric emergency management nurse, conducting targeted geriatric assessments in the emergency department and connecting at-risk older adults to further specialized geriatric care and services in the community. She then joined the inpatient geriatric medicine consult team, providing recommendations for the care of admitted patients with geriatric concerns through comprehensive geriatric assessments. Jennifer completed her master's in nursing with a leadership focus and special interest in delirium and patient and family education. Currently in her role as APN, she is committed to improving clinical outcomes for the older adult population through advanced nursing practice, program development, consultation, research, education, and leadership. We want to welcome Jennifer and thank you for joining us this morning.
Great. Thank you, Maris, for that introduction. Good morning, everyone. Welcome. So I'll be sharing a review of the delirium quality standards from Ontario Health. So we'll go over the quality standards and also highlight the accompanying implementation guide, discuss some other resources that are provided along with these standards, and then provide a few acute care change ideas and examples from the Ottawa Hospital. So why is this important to have these quality standards for delirium? It's important because it helps to describe what high quality care looks like for patients who are at high risk or people who are at high risk of experiencing delirium. Delirium is an acute medical emergency and needs to be identified. It's very common, especially in the hospital setting, ranging between 29 to 64%, depending on where in the hospital the patient is, how acutely ill they are. It's often unrecognized and misdiagnosed or misattributed to dementia because it can, the symptoms can range for different people from hypoactive, meaning like very sleepy and somnolent, to hyperactive, which usually is recognized a bit more because people experiencing hyperactive delirium are, often trying to get out of bed or having hallucinations, things like that. So the other issue is that delirium has major impact on the people experiencing delirium. So it's increased with shows increased mortality with delirium, prolonged hospital stays, decreased functional independence and cognitive decline, as well as increased need to be placed in a long-term care home. So very serious implications. And thankfully, there's something that can be done about it. Delirium can actually be prevented in 30 to 40% of cases. And this is through identifying risk factors and having tailored interventions to address those risk factors. It's really important to identify delirium early. It's a medical emergency. It means that there's something medical going on underneath that's leading to these symptoms. And so in that way, it's very important to identify it and try to do the workup to find out what could be causing this delirium. There are opportunities to involve specialized geriatrics if you have access to these services to help with managing delirium and looking further if there are other underlying issues, pre-existing cognitive decline, things like that that can be further investigated or followed up on later. So Senior Friendly Hospital also supports best practices related to delirium. And we can see that a number of organizations are implementing different strategies to address delirium. And we all know that it's an important issue and needs to be addressed. But what can often be challenging with these making change and implementing change initiatives is making sure that it works. How do you implement these change practices? How do you spread it? How do you get buy-in? And how do you make these improvement efforts sustainable? And so thankfully, we'll go through that. And this quality standard does have some advice and some strategies on how to make these changes stick and how to go about implementing them. So first, we'll go through and review the standards. So what I've done for each standard is gone through sort of why it's important, what it is, and how you might measure it and how you might go about it. So the first is identifying of risk factors for delirium. So this is a key element of these standards and maybe one of the newer ones to focus on for delirium. I know in our organization, this is something that we can develop and work on for sure. So it's important so that the healthcare professional can identify that delirium is a risk and is a factor for this patient and can monitor more closely. Not only that, but we can initiate some preventative interventions from the get-go. So it involves, like, what we want people to do is to assess this risk on initial contact. So as soon as the patient comes into the emergency department is a great time to assess risk for delirium. And so that involves getting a bit of collateral either from the patient and or family member or friends. We want to document this and communicate it so that the whole healthcare team is aware of this risk and can do their part to mitigate this risk. And we'll see as we go through these quality standards that each one really needs training, systems, processes, and resources to support any of these things we're asking healthcare professionals to do differently. So how we can measure it is looking at the percent of people presenting to hospital who are assessed for delirium on initial contact. This can be integrated into healthcare records and into the electronic medical records. And we want to show that this information is being communicated as the patient goes through their journey in acute care and beyond. So the next standard is interventions to prevent delirium. So now you know someone's high risk for delirium. What can we do to prevent it? So we know, as I mentioned before, 30 to 40% of cases can be prevented. The initiatives to prevent need to be collaborative, and this means it includes the whole interprofessional team, the person or patient themselves, and their family and caregiver. We need to know about them as an individual and tailor these interventions to their needs and their risk factors. It not only helps prevent delirium, but also other complications that are often seen with delirium, falls, pressure injuries. We can help reduce length of stay as well. So what are we looking for? These individual strategies that are tailored to the needs of the patient, but also the setting that they're in. We want to involve the person and their family and caregiver. So not only in identifying their risk factors and things that could help, but actually engaging in some of these strategies. Coming to visit at certain times, maybe meal time to encourage eating, maybe helping to mobilize the patient and go for walks around the hall in the hospital if possible. So again, we need that training and the systems and processes to support these change initiatives in the hospital. So a way you can measure this is percent of people at risk for delirium who have a care plan that's documented in their chart. So the next piece is early screening for delirium. So this is a little different than risk factors. This is using a tool to screen for delirium. So we know that it's often unrecognized or misdiagnosed, and we know that early detection of delirium reduces poor outcomes and helps the medical team get started on what is causing this delirium and trying to treat the underlying causes. It's usually a secondary diagnosis that isn't documented well, we find. So what does it involve? It involves doing a screening assessment, which requires getting a bit of collateral information. It needs to be done in a timely manner to identify, and then a workup needs to be done to find an underlying cause. So it needs to be a standardized and validated tool that's used for identifying delirium. So like the confusion assessment method, the new desk, there's a number of tools out there. And again, the training for staff to use this tool and systems and processes to support the use of this tool during the patient's stay in hospital. So we can look at the percent of people who present to hospital with risk factors for delirium and who are screened at different points during their hospital stay. And then having healthcare professionals who are trained in screening for delirium is another way that these change initiatives can be measured. Another key element that really is very important is education for people with delirium, family, and caregivers. So delirium, if you've ever had a loved one experience delirium or seen someone with delirium or families go through this, it's very distressing often for patients and for families. It's a big change that they see, and there's a lot of fear. Is this permanent? What can we do? So information and support and strategies that, giving people tools to help their loved one while they're in hospital to prevent or manage delirium can be very helpful as coping strategies for dealing with the delirium. It also encourages family and caregiver involvement, which is very key. We want to make sure that there's accessible education that's tailored to the needs of the patient and family. So in whatever form is helpful. Later on, we'll give an example of what we've done at TOH. And then a key part is giving people some ways that they can help. What can they do? Empower families to make a difference for their loved one in hospital as well is very key to this. So we can look at the percentage of people who have delirium and have received education, and the availability of education programs about delirium for people and family caregivers. So next is the management of delirium. And thankfully, the strategies needed to manage delirium are very similar to those that are needed to prevent it. So we're not reinventing the wheel here. So we know that delirium is a medical emergency. It really requires prompt recognition. The sooner you identify delirium, the better the outcomes for the person. We need to treat that underlying cause, whether it be an infection, new medication, electrolyte imbalances, dehydration, if it's, lack of sleep or constipation. These are the sorts of things that can be the underlying cause that need to be treated. So by treating this, we can reduce the duration, the severity, and the complications that accompany a delirium. So this involves a comprehensive assessment. It involves the whole interprofessional team to put together a plan, and it involves the patient and the caregiver. So at this point, this could be a good time to involve specialized geriatric services if you have access to them, to help, especially with more complicated deliriums. And then also for the follow-up piece. So often if someone has a delirium, there may be some underlying or vulnerability in the brain that may need some follow-up down the line. So that the training and the systems, again, are needed to support people in being able to manage, the healthcare professionals to manage delirium for our patients. So we can measure this by looking at the percent of people with delirium and who have also had a comprehensive geriatric assessment to identify the cause of the underlying delirium. We can also look at the percent of patients who have a care plan to address those symptoms. The next piece is about antipsychotic medication, which is sometimes used to treat the symptoms of a delirium. So there is inconsistent evidence about antipsychotic use with delirium, and these medications can be linked to serious adverse effects, but you really must balance the risks and benefits in hospital because there are some other risks to the patient. If they're in great distress with the delirium, if there's certain medical interventions that making it difficult to do those life-saving interventions because the patient is so delirious and restless and agitated. There may be some times when antipsychotic use is really warranted. So as mentioned here, for times of severe distress, as second-line management, we must always treat the cause. That is really the primary thing. But these medications can help with symptom management while that treatment is working through. We always start low and go slow. So what that means, like low dosages. And if we need to titrate up, we go very slowly to make sure we're observing and monitoring the response of the patient. And these medications really must be avoided in people with Parkinson's and Lewy body because they have more severe side effects for these patients. And then afterwards, when things have settled with the delirium, you must discontinue them and taper them down. So again, we need that training and systems and processes and resources to support our healthcare staff to use these change initiatives. So we can look at the percentage of people with delirium who have been administered antipsychotics. And then we can also look at things like the documented days where these medications are reviewed and when we're able to taper patients off the medications. Another very key element in delirium care is transitions. So a hospital stay is indeed a journey. You come in through a merge, you're in that environment, then you're admitted, you're waiting for a bed, you go up to a new unit, then from there you may transition to a transitional care unit, then from there so you may be moved a number of times as a patient and family member, and each time you're transitioned, you want that information, you want that continuity of care so people are aware of either your risk factors for delirium or that you have delirium and what needs to be done to manage your delirium, where you're at in that journey. You want that information to be communicated and passed on to other healthcare professionals. And this is also in between shifts as people are changing to make sure that that information is provided to your colleague when you're taking over care. And so we need this communication to be effective, as it's very important for the recovery of the patient, for that care plan to be continued by the next healthcare team that's looking after them. What's key to note about delirium too is even when the delirium's identified and it's being treated or been treated, it can take weeks to months for delirium to fully resolve. The other thing is once a delirium's occurred, there is a higher chance that you could get a delirium again. So these preventative and management strategies really need to be continued to make sure that the patient does fully resolve and do well and can be discharged to their destination. And by communicating through transitions, you're also raising awareness and making sure that there's follow-up and that people don't fall through the cracks. So again, we want to communicate that. We want to respect the goals of care of the patient and their family. We want to make sure that there are plans for follow-up and that there's that training and system and processes in place to ensure that that happens. So we could look at the percentage of people discharged with ongoing or resolved delirium to ensure that this information has been reported and documented at transitions. Okay, so that was the whirlwind review of the standards themselves. And as I mentioned, what we struggle with often in our organizations or really anywhere is how do you have this great change initiative and you want to improve care, but how do you make it happen? How do you get people to buy in? How do you implement it and make sure that it's sustained? And thankfully, along with this quality standard guide, they provided an implementation guide to help clinicians work through this, or leaders at different organizations to help them work through this. So I'll just give a few highlights of what's included in this implementation guide, and especially what I appreciated as a clinician, as an APN here, trying to make positive change for older adults. So the first step is to assemble a team. And what's really great is the Regional Geriatric Program in Toronto did a sort of workshop that clinicians and leaders in healthcare could sign up for. And they actually, had a workshop for each one of these steps to explain how we can be successful at implementing change, and went through each of these elements and had opportunity for discussion and questions and bringing great ideas. It was very supportive. So one of the first elements in the assembling a team part is how to develop an elevator pitch. So how can you sell how important delirium is to your colleagues and to others to get that buy-in? and get people who are wanting to take action with you and join you in your working group or whatever it may be. You want to provide a case for change. Why is this important? And then at each step along the way, it's so important to review, reflect, and refresh what you're doing. It's that sort of iterative process where you learn as you go. The next step is to prioritize a change idea. So what are we going to do? What are we going to really, there's a lot of stuff we could do, but what's the most important? Where do we begin? You want to get people in their feedback on what's important to them. So listen to what people are saying who are involved and who are impacted by this, and continue to gather feedback through the process. Gather change ideas. What can we do? And then review, reflect, refresh, and choose that priority area that you want to begin with. And then step 3, create a plan. What's your aim? Where are we going to pilot or start this project? What's the idea that we have, and the process measure? How are we going to see that we have an impact here? Test, make it stick, identify those barriers and strategies that have worked to overcome those barriers, and then keep going, basically. So some of the change ideas that were provided as well were really quite excellent. So they went through each standard and just kind of gave a few ideas to consider. So the identifying risk, you could create a checklist with all the known risk factors for delirium and develop a tool to communicate that risk. For the prevention interventions, you could have a standard order set, maybe a toileting routine, maybe, pain management, things like that. You could also have a toolkit for patients. Now, this I thought was really cool. So you could have a patient come in through Emerge and identify that they're at risk for delirium. And maybe within that toolkit, you have some activities for distraction. Maybe you have an information sheet about delirium. Maybe there's some tips for families of things to bring in from home. It could be a number of things to help with patients. Maybe it's, the socks to prevent falls, etc. And then have some established universal prevention strategies that are accessible to everyone that healthcare professionals know about and can be used for patients. Early screening. So what's your tool? What's the screening tool that's going to be used at your organizations? Keep it consistent and have training for people to use that tool. Develop a written handout for patients and families to provide that education on delirium. Management, have a comprehensive assessment that it's used. Have buy-in from the interprofessional team that everyone's involved in the management of delirium. Maybe for the antipsychotic medication, there's an order set or some guidance on prescribing these medications through either an order set or a flag system in your EMR, let's say. And then transitions, have a mandatory field in your electronic medical record where people can document the presence of delirium and also have a standardized coding of delirium so everyone knows what it means. So just a few great ideas to start with. They also go into what some barriers you may encounter and some strategies to address these barriers. So you may hear, well, the healthcare professional is lacking the knowledge and skill to do any of these change interventions. Well, let's provide education. And there are so many learning series and modules and different programs out there. Senior Friendly Hospital Care has a learning series. There's Gentle Persuasive Approaches. There's a number out there. The next barrier could be the healthcare professional is forgetting it in their practice. They're forgetting to do it. What can we do? Maybe there's a reminder clinical pocket card that can be developed, or there's audits that are done on the units and feedback and reports to help reinforce these change measures. We don't have time. We hear that a lot. So engage patients and caregivers as partners in their care. They can also be the ongoing reminder and the sort of the engagement that you need to get the healthcare professional on board as well. Promote delirium care as everyone's responsibility, because it truly is. and then have a way to measure your overall success. So there are some indicators from provincial data that are recommended. So looking at rate of delirium with onset during hospital stay, or percentage of people discharged from hospital to home with delirium. And there's also local data that you can look at. So the percentage of people at risk of delirium who have interventions through a care plan, and then percentage of people with delirium with interprofessional management plans that address the cause and symptoms. All right, so then this last part of our talk will be about some of the other resources that are also provided in these quality standards, and then also to share a few ideas that have been done here at TOH. So in addition to the quality standard, there is also a patient guide. And the patient guide can be shared with patients and families to encourage conversations about delirium. There's a measurement resource with technical specifications for indicators, so sort of the case for improvement. They also provide a slide deck to share with others about this quality standard. There's a getting started guide, and this guide has links to templates and tools to put the quality standards into practice. So tools to help plan, implement, and sustain change. There's also something called Quorum, which is an online community that's dedicated to improving quality across Ontario, where practitioners and leaders can come to share information, to support each other, share tools and resources, just like a networking opportunity. And then there's a quality improvement plan also provided for organizations to outline how organizations plan to improve quality of care and provided to the patients in the coming year, so to make a plan organizational wide. So it really is a full circle support for these quality standards, not only just stating what they are, but how can we really make change and sustain it and support each other through this, knowing that it is very challenging to do and to do well. So next we'll go into some TOH examples. So we'll talk a bit about a patient and family education guide that was developed, and also more about our policy, so that the systems and training and pieces to support the ongoing change for delirium that's mentioned. So here's a picture of a few years back, we developed a one-page delirium education form. So the goal of this was that it could be used as a tool for the healthcare team to open the conversation of delirium, provide some information, what is it, and what can you as the family do to help us to provide better care for your family member. So as you can see, it has a definition of delirium, what does it look like, what are some important facts about it, and the important role that family and caregivers can play in notifying the team that they see a difference in their loved one. There's something going on here. We think it's delirium, but not only notifying us, but then how can they play a role in preventing and managing delirium? So again, about telling the team and helping to reorient the person, bringing in those glasses, hearing aids, and shoes, displaying familiar things and items, socializing, talking, helping to promote sleep, mobilization, and really healthy foods and making sure the person stays hydrated. So these are all ways that family members and caregivers can really, really play an important role in their loved one's care in managing delirium. So this is available. We have it available to be printed or on the units so that it's very accessible. And we have it in French and English as well. And we found having it just pretty short and to the point was quite helpful. It's sort of it's a more palatable way to receive information pretty quick, so that the nurse or whoever is giving the information can do it in a timely way and then come back to answer questions. And then there's linked to further information at the bottom if people want to learn more or have more questions. And so it's worked pretty well. So next I'll go over some of the work that's been done with our policy at TOH, or now it's called a standard operating procedure. So we've had this policy for quite a number of years, and every I think 3 or 4 years it needs to be reviewed and updated. And so the review of our policy happened to align very well with the release of these quality standards. So we were able to really intentionally make sure that we were covering all of these standards within our policy. So it was a really great timing for us. So one of the key things is we wanted to expand this to be a corporate standard operating procedure, meaning that, not necessarily, not just for nursing or whatever, but for the whole healthcare team, and how we all have a role to play in identifying, or in preventing, identifying, and managing delirium. And as I said, we wanted to build in each quality statement to ensure that each part was covered in our SOP. And with the use of our relatively new now electronic medical record, we wanted to really align the workflows in Epic for our healthcare team with some of these standards, to make sure that, like we said, that those processes are there to support the care and these standards for delirium care. So that includes, what tools we're using, how we're documenting, and ways to alert people to delirium. So what we did is we created sort of this general workflow of what's going to happen for this patient and for the healthcare staff that are looking after them. So at TOH, we use the brief CAM, the confusion assessment method. So we use that as our screening tool. And essentially, if there is a positive CAM, we want to make sure that the medical team is notified and they're aware, so that a delirium workup can be done. We want to make sure that there's a care plan applied, so that we can put in those great interventions to address the underlying causes of delirium. That there's required documentation, so that CAM tool is repeated over time to ensure that we're improving their condition. We're working on getting a banner so that if a patient is delirious, it's clear on their chart that they are delirious, and that everyone needs to be aware and to do their part to help manage and improve the delirium. And that day to day we can document a person's progress and how the interventions are impacting their outcomes. And then, of course, if the CAM is negative, it doesn't stop there. We still need to have preventative care plan pieces in place for our patients, and we want to continue to assess at least once a shift for any changes in thinking and behavior that may mean that a delirium is developing. So this is, I mentioned, our screening tool that we use is the brief CAM, and this was brought out a few years back. What's great about this tool is it's very straightforward, and a beautiful algorithm was developed to really help walk people through. We want to make sure they're trained and able to use this tool effectively. And so, as you can see, hopefully, it really takes you through question by question and gives you objective ways to measure each piece. And this is actually embedded in our electronic medical record. So when people go through and fill out this CAM on the charts and using the system, it actually takes them through question by question, and automatically, as the questions are done, will take you to whether it's CAM positive or negative. And then what happens is, as soon as a CAM tool comes up positive, it actually automatically pulls in the delirium care plan into the patient's chart. So we have an electronic care plan that looks a little bit like this. So this is what the delirium care plan would look like, and within it are there are certain goals, there's an issue or a problem, and then there's the goal, and then the interventions that are associated with that. So for example, you can see here that a new environment is an issue for delirium. And so the goal is to orient the person to the environment. And you can see here that there are a few interventions listed. So providing gentle reorientation to time and date, ensure it's written on their whiteboard so they can see it, there's a clock in place. They're wearing their glasses and hearing aids. So different interventions that are there to cue the healthcare team on what sort of care interventions to focus on, and then they can actually document on that right within the care plan. So here are a few other examples of the documentation. So as I mentioned, the confusion assessment method is here and walks the healthcare professional through while they're filling this out to do the CAM tool. And there's actually on the, when you open it up in the electronic medical record, there's we call it the flow sheet where they fill that in. And on the right, there's a panel that opens that actually shows can explain the algorithm for the brief CAM tool. I mentioned too, day-to-day ways to document different, sometimes there are some behavioral responses with the delirium. So these can be documented under this. There's a psychosocial section with patient behaviors and mood, where that can be documented pretty quickly. And then you can see over time the trend of, maybe there's certain times of day when you see more behaviors. So you can kind of use that to help determine underlying causes and ways to improve the delirium management. Another key part of our electronic medical record is that we have these things called navigators. And all that means is it pulls all the pertinent information for that workflow or task into one panel so that the healthcare professional going through has it all in one space. They don't have to jump around. So what's been done here in the admission navigator is part of our policy is that a CAM screening tool is done for every patient who's admitted to hospital. So you can see that there's a whole cognitive assessment piece in the admission. This has to be done, I believe it's within 24 to 48 hours of admission. And there's spot also to put in certain risk factors like the person's baseline cognition, any behavioral concerns, any recent changes in cognition. And then it has a link to the actual confusion assessment method right within that navigator to cue people and support them through the system to complete these workflows. I also mentioned the transfer of care piece. So we have a transfer of accountability navigator that's used whenever a patient is moved to a different area or going to a test or things like that. So there's actually a part on it that says care interventions in the next 60 minutes. So there's a spot there where you could write that the patient is confused, they need supervision on transfer, any key point you could say the patient is delirious. There's also a discharge navigator that I haven't shown here, but there's a section there where you can write any free text, any key things to follow up on. So for example, if our geriatric team's involved and we know that a delirium occurred and that we've arranged follow-up, so on the discharge summary for the or after visit summary, it'll say when the next appointment is, and we could write in, that delirium, this is follow-up for delirium in hospital. Be aware that if another delirium occurs or there's an acute change in behavior thinking, that go to your family doctor. So we can put in these key things to notify families and the receiving family physician about the delirium and the follow-up that's been arranged. So just a few ideas of how these delirium standards can be worked in to our various electronic medical records and systems and processes that we have in our organization to support our healthcare workers to successfully put in place these change initiatives that we're asking. And then I've just referenced here the Health Quality Ontario website where you can find the standard and also all of the accompanying documents and resources to help you implement change, measure change, and get more support for whatever change initiative you want to do. And that's it. Thank you very much. So we're open for questions or comments at this point.
So thank you so much, Jennifer. That was a great presentation, very comprehensive.
Thank
So
you.
as we move to our Q&A time, just a reminder to please use the question and answer button and to ask your questions. And if you can't find the Q&A button, you can also use the chat room. And then, so the next question is, I wonder if you could say anything about one, the completion rate of the BCAM, and also two, the positive score rates. Do they match the real rates of delirium?
Very good question and point. I don't know specifics, but I would guess that it's not ideal, right? So keep in mind, we're not perfect with all of the policies and things that we've put in place. There's still a lot of work to do in terms of well, one piece too is with our new electronic medical record, we're still working on certain dashboards to be able to measure delirium rates and care plans, whether they're being implemented. So there's still work to be done to validate that data for sure. But I'd say, you know, I think it's a lot better than it was quite a few years ago. People are far more aware of delirium. They're using the tool, especially because we've worked it into the admission. It's a required documentation. It's also required once a person is positive CAM, it becomes a required documentation the next shift, and it pops up for the nurse to complete. So in that way, the rates are good. You know, they're being done consistently on admission and when it's being prompted. And then because the care plan is automatically applied, we know that that's happening as well. But are we missing some deliriums? Yes, probably we are. Yeah. Okay. So I don't know if that fully answers your question, but I think it's a good one. It highlights, you know, the need to go back and refresh and train and make sure that people know the tools there and how to use it effectively and what it means. And that ongoing education is so very important. Thanks for that question.
So we have a couple more questions. So any suggestions on teaching nurses how to correctly use the CAM?
So, I mean, I think that's why we like the brief CAM, because it is fairly self-explanatory. It really goes through, like, it provides all that information. I think what people really struggle with is that first question about, is this an acute change? Because often in acute care, we don't always know the patient's baseline. But that's where some of these other standards come in about, like, identifying risk, understanding some collateral about the patient, what their baseline is, and taking time to learn that right away. But the reality is sometimes, you know, we don't know that information. So what I always try to teach, and what we teach is, if you're not sure if it's a change, but you've noticed something is off, your answer is yes. You're better to assume a delirium than to miss a delirium. There's no harm in preventing and managing delirium and looking for, doing a few other tests to find out if there's something else going on for this person. So I always say err on the side of, yes, they're delirious. You don't harm the person by doing that. You harm them by missing the delirium. So I'd say that's the hardest part of the CAM tool, is there an acute change? And then, helping people to work through that. And then the rest of it is pretty, like, there's objective ways to measure attention. There's, you know, saying the days of the week backwards or the months backwards. There's certain questions about disorientation that you can ask. So that algorithm really does help.
Next question. What did you find was the easiest change strategy to implement with regards to the new quality standards?
Well, I must say we're working through it. So I know, so before my time, that's when the brief CAM was put through, which was really great. So there was a lot of work done in just raising awareness about delirium, how important it is. We have I think it's pretty straightforward to put in place, like, order sets. So, like, a delirium order set is pretty easy to do. I mean, I wasn't involved when that was done, but I think, you know, like, you can highlight what sort of key, the research shows what delirium workup tests are needed, and then putting that in as a resource so that physicians can just go delirium workup, boom, everything's there, and they can click off which tests they want to do for the patient. So I'd say that's a pretty straightforward one. Another one is the care plan. So there are well-established universal strategies for preventing and managing delirium. You could find it anywhere. You can, tailor it to your organization, and just having that established as a universal care plan to implement that people can refer to and put in place for patients is also a great place to start. Where I think we'd like to work next is more about that risk assessment piece. We have the screening tool now, but what can we do even upstream to look at risk factors for delirium? Just put it on people's radar, like, oh yeah, someone's had a delirium before, or there is some cognitive impairment, or they're quite ill, they're going for surgery. These are really key. They're older age, these are key risk factors. Let's put this on everyone's radar, so we're all looking out for this patient, is sort of the next phase, I think, for us.
Perfect. Thank you. Another question. We have a couple here. So does the TOH have an automatic referral to specialized geriatric services when a delirium is identified or if a person is at risk?
So we don't have an automatic referral. It's an interesting idea. I don't think if we were referred to every single person in hospital who had a delirium, we could not do it. There would be far, far too many patients to see. So our goal here at TOH is to really build capacity across the organization so that everyone is aware of delirium, how to assess risk, and how to put in these automatic care plans and to individualize them for patients, so that we're all on the outlook or on the lookout, for delirium and doing our part to prevent it. Really, that's key. And then there are the more challenging delirium cases. So to empower everyone and build that capacity so that everyone can address delirium. But then for the more challenging cases, that's when you use your specialized services to get involved, so that we are using resources appropriately, if that makes sense.
So this is a follow-up question to one of the questions that you answered earlier. So if the BCAM is being repeated during the admission, do the nurses and/or patients find it burdensome, especially after a few days?
It's a really quick assessment. It's really quick. And once you get to know the patient too, you can see the fluctuations and see if things are improving. So, I mean, speaking for myself, I wouldn't say that I know when we first put out the brief cam, there were some surveys done, and I think it was well received by staff. So I really, in terms of screening tests, it's one of the more quick screening tests. I think it's not so burdensome. And you know what? It's just really good practice. When we're doing our assessment of the patient, when you go to meet them, you're seeing, are they alert? Are they responsive to me? Can they follow instructions? Do they answer appropriately? All of those pieces are just part of when you go into the room and you're doing your head to toe assessment, should really be a part of your day-to-day assessment anyway.
So it looks like we don't have any more questions. I just wanted to say that in the chat box, we have uploaded the delirium patient guide that you presented. So it's in the chat box for those, if someone was looking for it. So I just want to put it there.
Great, thank you.
And I think that might be it for today. So I want to invite everyone to check out our website at www.rgpeo.com/events to view or register for any of our upcoming educational events. So just so that you guys know, we have regional geriatric rounds on April 25th, and the topic there is ageism, influence on how older people are viewed and view themselves, and that's by Dr. Allison Chastin. There's a geriatric education series, so we still have limited space, but we have a 2-day core introductions to geriatrics on March 28th and 29th. And that is virtual. On May 2nd, we have a 1-day focus on medical information, so that's there as well. And we also have the geriatric refresher day on June 15th and 22nd. So I want to thank you again, Jennifer, for an informative presentation, and thank everyone for joining us today. And we hope to see you at the next regional rounds. So thanks everyone, and have a wonderful day.